you know, when you look at the literature, you look at the systematic reviews that have been done, when you look at all the literature that you've published that's come from your group, why do you think there is still debate? People are, it kind of sounds like there's compelling data to support the fact that maybe we should be doing one stage, and compelling arguments from a healthcare point of view. I mean, we come from Canada and we have limited resources. The other thing that I noted when I watched you do that video is, you know, I don't do a lot of joints, but I do a lot of infected non-unions, and I treat the infected non-unions like a tumor operation. And I see you guys doing that exact same thing, treating it like a tumor operation. So I guess my questions are twofold. One, why do you think there's debate? And two, you know, the technique is so critical. Do you think that plays a role with respect to this debate?
That's really a great, thank you very much, Brad. That's a great question, to be honest. I'm always wondering why this question is not asked on the meetings, because so the answer, I don't know the answer, to be honest. As you mentioned, I mean, the results of the one stage during the last 5 to 10 years are much better. Not much better, but at least the same results as for the two-stage exchange, at least. And you need only one surgery. So everybody should perform this kind of surgery. But first of all, surgeons are a very traditional profession. And two-stage was a gold standard for let's say 40, 50 years. So it's not easy to change for many surgeons. Point two, you need for the one stage, and I focused a little bit on it, a lot of experience and a lot of cases. And as you said, if you are doing a septic non-union, you must exactly define the border to the healthy tissue. And this needs a lot of experience, and not all surgeons have this kind of experience, and they think it is safer for them to perform the two-stage, to have at least one more option, you know. And they are very afraid if the one stage fails to do another one stage or two stage. So it's really, for many surgeons, a big mountain in front of them, full of dangerous pathways. So I think that's the reason. It's more mentally. It's not really based on rational.
Yeah, there's also that.
Okay.
No, you go.
I was going to say, just in terms of process, for those of you who have questions, I see lots of questions popping up on the chat. We would love it if you would either unmute and come to video and share your thoughts with the profs here as well, because this is the opportunity. This is your chance to really interact. So as many of you as feel comfortable, please go to video. And let's, for those of you who have questions, I see that Section has a question. I see that Mola Shazi has a question. Sunny has a question. Why don't you come to video and maybe ask those questions? While you're doing that, I'll let Brad continue.
I would like to add maybe one more sentence about the first question. Why is there still a debate?
Yeah.
Maybe one of the reasons could be because if you look in the literature, if you look at the timeline, we started very early. We were the first. They introduced the one-stage exchange. But I think in the past, like in the recent years, there were studies missing presenting the results after the one stage. Because if you look at the two-stage septic exchange, you have tons of papers. But if you look at single stage or one stage, you see that you have an increased number in the recent years. So that's the reason, that could be the reason why the single stage is getting more popular worldwide, because the people are seeing the results, not only from the endo clinic, they are seeing also from other hospitals, they can achieve successful results. This could be the reason why the increasing trend in one stage. And I think if you have more papers, if we have randomized controlled trials, we will we can say more, but I think we will have the debate after 10 years also. because the surgeons are performing two-stage, they prefer two-stage because they learned it like the two-stage septic exchange. They will follow always the two-stage. And I think if we have randomized control trials, I think we will have the debate in 10, 15 years or in 50 years maybe.
But to that point of the randomized trial, do you believe in your heart of hearts that a randomized trial is truly needed? Is it either too split, or do you honestly believe that we need it? Sometimes in surgery, the effect size is something that you can see. Should we spend the money as an orthopedic community on a randomized control? Do you think there's enough equipoise here?
If you look on the, maybe, of course you need randomized control trials, but also you need really huge studies with huge patient numbers. I presented two cases, comparative studies comparing one versus two-stage. But if you look at the number of cases, there are 20 more, maybe 100. What we need is, I think, of course, randomized control trials. But I think even what is better is we need really high volume, like hospitals, maybe like our hospital with huge numbers, maybe like we have done more than 10,000 cases now, and also huge centers performing the two-stage. So if you have a comparative study with maybe not 20 cases, maybe with 1,000 cases from each type of treatment, then you can see maybe the difference or the similar comparative, comparable results. And if you have like similar results in those huge numbers, I would say this could be a solution to reduce the debate. Mm-hmm. Of course, you cannot perform the one stage in every patient. We have contraindications, Professor Gerke mentioned already, and here's one of the questions: what about culture negative infections? This is one of our contraindications. So in those cases, we are not doing a one-stage exchange.
It's always good if in one staff or in one hospital, not everybody has the same opinion, and I'm not fully agree with Mustafa, because I'm not a big fan of these randomized trials, because there are two groups all over the world. The INFORM study, they did a quite high number of cases in the meantime. They didn't publish it yet. We are waiting for this since 5-6 months. And there is another group, which in US, which is led by the Auto Carolina group around Tom Ferring. And they haven't done so many cases yet, because in my opinion, randomized trials in such severe disease, it's like a tumor, that this have some ethical problems, because when I'm sure I can solve a case with a one-stage exchange, I'm really sure that I can solve it with one-stage exchange, and he is randomized for a two-stage exchange. I think this is very critical, you know. This is like a tumor. If you do it in tumors, this is in tumor surgery, there are not so many randomized trials. I don't know any really good one. So I think it's the same with the periprosthetic joint infection. It is good that there are some attempts, but I'm not sure if they give us the information that we are expecting from it.
If I jump in too, I think, you know, this is very, very parallel to anything where there's a huge degree of technical ability as well and judgment involved. So for example, the argument we've used for big trials, big ones have been in, you know, maybe all the big trials should be done in the primaries, you know, in the primary joints, where you're trying to say, okay, can we make an incremental change that won't be an absolute critical difference? Same thing as when we're talking about hip fractures, big trials versus the acetabular fracture. You don't see very many trials in acetabular fracture care because the technical components of that are so difficult and unique that randomizing would lead to probably more confounding and more problems than it would otherwise. So it's a very interesting dilemma. And the biggest challenge, having done trials my whole life. So, Thorsten, I'm coming from a point of view of thinking, can we do a trial? And then with some age, a bit more gray hair, you look back on your life and you say, the most dangerous thing in the world is a small trial that has a wrong answer, because everyone believes it. They will ignore the large, thoughtful, 20-year series of a very expert group of surgeons, because a randomized trial of 50 patients on PJI showed something. And then you will spend the rest of your career battling that one small paper. And that's actually not helping our field at all, because if it's wrong, the challenge we find is small RCTs, and you know this, Mustafa, and all of us here. And I know Parag, I see Parag here as well, and a number of others in Sachin. These are individuals who are very, very keenly working on developing groups. I know in India has a very large group. I know many of them are represented here. How do we get big groups? So if you can pull off sort of in a revision study with tens of thousands of revisions, with everyone aligned on something that would make sense, all for it. But this, to me, there are so many, and I'm curious what other people think, but I think in some ways, there are so many unique features of your protocol that you have to do the whole protocol exactly the way you do it and compare it to something else, because any deviation of that protocol could lead to what we call residual confounding and problems. So anyways, it's a fascinating area. And, I've been thinking, and we've been chatting a lot about what the next big questions are. What do you think, to anyone here, who's on this panel, including those who are listening in, what should be, if we're going to do one study as a global community that could be done, what would it be in your mind? And I know, Thorsten, your viewpoint may be very different now, because you're thinking probably not, in a 1 versus 2 stage infection is the study to do. I know, Mustafa, you suggested it is. But if you had to get everybody involved, what would be some of the big burning questions? I think infection is the outcome of interest. But what is it? Is it the type of irrigation? Is it the primary? A 1% or 2% difference. People have spent decades reducing the 2% cardiac mortality rate to 1%. And they've done it. So to think that there's no story in a primary joint with this very simple irrigation technique or something simple or frugal, to me, could be majorly, you could solve a big problem, because the number of joints, 2% represents a lot of infections in primary care, or 1% even. Anyways, I'm raising some hypotheses. I'm curious what people think. You're all the experts. I'm just trying to figure out where we would go.
I presented the results about the length of antibiotic treatment. This could be a really important study. So what is the optimal duration of IV antibiotics? Because this is a question we are receiving in the majority of meetings. We are performing only 2 weeks. And I think, do we need, or do we have to take longer antibiotic treatment in specific germs, like, for example, enterococci infections, streptococci infections? And I think in those type of germs, it could be very, very important to find a question for this question, to find the answer for this question. I think the length of treatment is
you mentioned, let's ask the
okay.
participants. So there's Alberto from New York. There's my friend Parag from Pune. There is Idemar from Brazil. So many people from all over the world. What do you think, Alberto?
So first, Thorsten, Mustafa, great to see you, and wonderful talks. As a person who has trained in North America and then had a chance to visit your institution as well as a few places in Europe, I can say that the 2 words that you used in your presentations, which were the most important for me, are debridement and standardization. And I think that was what impressed me in my time, is that all of the septic surgeons there do the same thing. And in some institutions like the one I'm in right now, we can't even agree as to what irrigation solution we should use, or if we even turn the room over or not, which I know is something that you have never done in all of your experience. Wow. So to me, I think, as I'm interested more in the pathogenesis of infection, to us, 2 weeks of antibiotics is something we never do. We give a huge dose for a long period of time, But really, we have to go back to the pathogenesis. It's biofilm and it's bacterial infiltration into tissues. And the fact is, in your technique, in one fell swoop, you're able to eliminate the biofilm and maybe not all, but enough of the bioburden through your radical debridement that then the antibiotics and the host immune system are able to take care of everything. The answer as to why a two-stage would be worse or would be the same as a one-stage doesn't make sense, because if we're doing the debridement and then we administer the high-dose antibiotic cement, we should have achieved the same thing as the one-stage. So as a person actually who does a lot of two stages because of the host and the concerns of the immune system that we have in our population, my main concern is when I'm thinking about doing a one stage, it is technically frightening. We're removing a huge amount of bone. The reconstruction is more precarious. The postoperative care is more dangerous. And patients are really coming in saying, how can I get back to function and independence? So it's very hard to tell them I'm going to amputate a portion of the soft tissue envelope. But ultimately, in your institution, you're able to get that, make that work. And I think it has to do a little bit with the antiseptic solution. So I'm doing a lot of in vitro work to see what works on biofilm. We still don't really know that. A lot of the data that we have is over 10 years old and even comes back to open fractures, which Professor Bandari worked on many years ago. And that still continues to be the voice of reason. So I think we have to do better in learning how we can kill bacteria in the immediate operative time. That's the interesting thing for me. And then that's how we can have a more standardized surgical approach. But the fact is we don't all do the one stage in the same way, and that's a problem.
Well, can I just jump in on that one point on irrigation solutions? Is it reasonable, like, because right now, when you talk to some groups, they'll say you can only use iodine based because that's the only thing that's safe. Then you go to another group and say, no, you can use chlorhexidine based. My simple mind says, wouldn't it a very simple, frugal, rapid 20, 30,000 patient study we could do, and I'm being serious, we could do very quickly, would be just looking at three options, or some combination thereof. Am I missing something? Like why is there such a strong perception that only iodine is the irrigation solution?
We are using, instead of iodine or chlorhexidine, we are using polyhexanate solution, which is very, very good solution. So, but that's a great proposal. So that's easy to perform. Right. In the consensus meeting, we came to the conclusion that probably iodine is the best one, but is driven by some groups, of course. Always.
Yeah.
And but it would interest me. So, Parag, are you there? Parag, just your picture.
He's around. Sachin, find him.
You put your picture on it. So
well, you know what? But Sachin is, and I know you guys are all linked with the ski group. Sachin, maybe you can speak to this issue.
So yeah, I think thanks a lot, Mohit, for organizing this, and hello to Thorsten, and thanks Mustafa as well. Yeah, so it's, I think, a really pertinent question, and I did have a chance to hear Mohit speak to us when he was there in India about looking at this particular study here. Now, the thing that really I feel is of concern is that the whole philosophy, or the most important point that all of you drove across, was that you can do a one stage only when you have identified a bug properly. But unfortunately, with so many methods of identifying bugs, we still don't have a gold standard of how do we identify a bug. Do we all do a 3-day culture? Do we do a 7-day culture? And based on that, can we have certain recommendations from the group? We did speak about them in the ICM meeting, what would be the best way. But, what would be the ideal bespoke way to really identify a bug would be something that would interest all of us across the whole world, of course. And coming back to Mohit's question, what about irrigation? I think that's a really pertinent question, because it's probably 6 evidence that all of us follow here that, I feel that this is good for us. And nothing more than that. It's worse than expert commentary there, and it would be really a fantastic thing to really have sorted out to, really have some concrete evidence on the same. Not just what goes in the solution, but how much goes in the solution as well. How many liters of saline? I think that's also pretty important there.
I think that Pedro raises a good point. I see here. How much of the, and I'm not sure where he is, but you may want to comment, Pedro, on that quality of debridement, and like how much confounding does that play? Because the debridement is huge here, and then you're talking about randomizing to solution.
Yeah. Hi, I'm Pedro Foguet. I'm a Spaniard working in England. I was passed the link to this Zoom talk by one of my colleagues in the department. I heard of, well, I know many of you, Torsten. I heard of Mohan Bandari through my good friend Matt Costa from Oxford, and many of your names are familiar to me. So I'm interested in PJIs. I was in the consensus meeting in Philadelphia as well as one of the British delegates. So I think, you know, it would be great. And I'm also part of the trial run by the guys in Bristol. We contributed numbers of infected hips, which we were happy to randomize to 1- and 2-stage revisions to build up the numbers, yeah, the INFORM trial. But I think that when we talk about infections, the basic intervention, the first thing that we all do is debridement, you know, and what you consider a good debridement might not be that good for me, or vice versa, you know. And what I would want to have is a very clear, you know, guidance on what represents a good debridement. I know that Torsten and most of you do a good debridement, but since we haven't got that foundation, you know, any attempt to do research comparing results becomes quite irrelevant, you know. I can tell you of my own experience. When I started doing infections 15 years ago, I was not very confident about my debridement. I'd been a fellow in Oxford. I was doing everything in 2 stages. I got fed up of seeing my patients, you know, dying in hospital from other complications, because in Coventry, although it's Britain, we are not very affluent, and we had to keep them in hospital in between the stages. And, you know, they were petite old ladies and gentlemen getting infections of the waterworks or chest, or getting DVTs and so on. You know, and then I visited the endo clinic, which was that mythical place, and I was very well treated, and I loved what I was seeing there. And, you know, I moved on from spacers to the Kumars, which is what you were showing more or less, Torsten, yeah, poorly cemented joint replacements. Patients were able now to leave the hospital, and you know, and then as I got more and more confident with my debridement, I started cementing them, the prosthesis, even better than what I had been doing at the beginning, particularly in all the people who didn't have much of a reserve to come back after a few months for another stage, yeah? And then we moved from that, and now we are in a phase where we are so confident, and we also developed an MDT. We have good infectious disease specialists, good microbiologists. We are a group of surgeons, all of whom have been trained by me. And we help each other, we support each other. We are in a phase where we haven't even taken the culture negative PGIs, and we do them in 1 stage for some specific cases, you know. And we are about to publish our results where we are showing pretty good survivorship with those patients, with excellent functional recovery, you know. And I don't know, I just wanted to be a little bit, you know, say something which is not what you always say in those meetings, something crazy if you want.
Pedro, thank you so much for this comment, Pedro. So, but the question is really, that's a really probably the most important question. What is a good debridement? And I'm telling always my fellows, if you think you have done a very good debridement and finished your debridement, then you start with your real debridement. You know, that's my philosophy. So, but as Maud said, so there is the technical skills are playing a big role, and exactly what you have done is typical. You did more and more aseptic exchanges, and then you shifted from the 2-stage to the 1-stage more and more. And this is what we see in many specialized centers all over the world. Probably it has really a lot to do with, as I mentioned before, with experience.
Yeah. And I think this gets, once again, Pedro, I think what you have done is you've re-emphasized how difficult it is to do a high quality randomized trial in a very difficult area where technical ability is so important, or technical experience is so much more important. And so even if we did a simple study and we have to adjust for that, then you get back into all the confounding, right? Because if something shows a big, if it just happens that the surgeon who is the more superior and complete debrider, that surgeon may in fact have better outcomes. And we're going to somehow wrongly attribute the intervention to that side, which is in error. And that's the danger that we face. And that's why when we're thinking of the big platform global trials, large questions by definition have to be very simple. The more complex the question, the more you have to start thinking of going to experiences. And I'm using the example of the endo clinic as one important experience, and thinking, how do we standardize, educate, and then think about how to do that go forward. But we could be spending many, many, many hours here today, friends. And the challenge is that we are at our hour. What I would recommend we do is, if you like this format, we'll reconvene at another time, and I will find a way to entice our good speakers back to talk a bit more about these issues. I think there's lots we can discuss that'll come up from it. Lots of questions that were posed in the comments. We'll encourage our speakers also just to follow up and give you some of those insights. But again, today was really about this. And I'm hopeful that you found this to be a slightly more engaging than a webinar format. It's been our hope. I cannot thank Mustafa and Thorsten enough. And I think I will leave the last word to our keynote. Thorsten, maybe to end this session.
Oh, thank you so much. That's a great honor. So to be honest, I did, let's say, about 50, 60 webinars during the last 4 or 5 months or 4 months. And this was by far the most interactive webinar I've ever attended. So congratulations to you, Moet, because I like this format. I had a webinar last week with 7,500 Chinese doctors. So, I mean, it's nothing. So in this format, congratulations, that's a great, great format. And I like to thank you really. So this hour went on like this. And thank you so much for organizing this webinar, which is probably the best form of education at the moment under these difficult circumstances. Right. Thank you so much. And thank you all for attending this meeting. It was great. Thank you.